Okay, thank you. I'm going to speak a bit about what I've been doing for the last 4 years in my role as Associate Dean of Continuing Medical Education. And I'm hoping that at the end of this talk, um, uh, you'll have an appreciation for what audit and feedback is. I'll talk about what we've developed here at our university called the Calgary Audit and Feedback Framework. And I'll talk about my work with the Physician Learning Program and how we're trying to transform how we do continuing professional development in Canada to change physicians' behavior and improve adherence to clinical practice guidelines. And I'll start by why this is an important topic. We know that there is a knowledge to action gap from where research findings are developed in a research intensive university to where they are put into clinical practice in the hospital setting. And my program called the Physician Learning Program is helping bridge this knowledge to action gap in our center. We also know that there's patient safety issues, and this report from the Institute of Medicine 20 years ago in the United States highlighted that far too often healthcare can harm patients. Too frequently, it routinely fails to deliver on its potential benefits. And it emphasized that a high functioning healthcare system needs to be one that should deliver care that's equitable, effective, efficient, safe, timely, and patient-centered. And third, in my country at least, where we have a publicly funded healthcare system, there's a sustainability issue. We currently spend over 11% of our gross domestic product on healthcare, and this is rapidly increasing. And we cannot continue to spend this amount of money, especially after the downturn in our economy with COVID. And we also know from a group called Choosing Wisely Canada that we probably do 1 million potentially unnecessary tests every year in Canada. Approximately 1/3 of our testing and treatment is unnecessary and therefore may result in harm. So I'm the Associate Dean of Continuing Medical Education and Professional Development, and I'm going to tell you why this name is important. Continuing medical education is what I've been doing today at your conference. And again, thank you for the invitation. As a teacher, I'm talking about medical facts, one directional, and maybe this improves patient care. But we actually have a problem with measuring how impactful continuing professional development is. Sometimes surveys are filled out. Did you feel you learned anything? But what we really want to try and prove is that our professional development is leading to healthier patients and healthier communities. So this study is actually from a few years ago, and it showed that interactive CME sessions where there's participant activities and opportunities to practice skills can effectively change professional practice and on occasion improve healthcare outcomes. But based on a small number of well-conducted trials, didactic sessions like what I'm doing right now do not effectively change physician performance. And we've had this ballistic model of medical education where doctors, we train them in medical school and then residency, and we launch them at the end of residency into practice. And we hope that like a bullet being shot out of a gun, and the bullet slowly falls to the earth, that their knowledge slowly will go down over time, but it will not get below this acceptable performance where they may be harming patients. And we try to nudge this line upwards by doing continuing medical education. But there is evidence that as we get older, our knowledge and skills do go down. And this is a study from the United States that suggested that patients cared in the same hospital by an older physician compared to a younger physician had higher mortality. So maybe our model of how we do continuing professional development needs to change. Now, in Canada, we have 3 different systems for how doctors maintain their competence. Specialists like myself go through the Royal College of Physicians and Surgeons of Canada. Family doctors go through the College of Family Physicians. And then in Quebec, which is a distinct society, they have their own way of doing things. We, every 5 years as specialists, have to collect 400 credits to maintain our license to practice. This can be from reading journals or attending conferences, but now some of it has to come through assessment activities. And this doesn't have to happen for family doctors yet, although in Quebec, all doctors, whether you're a specialist or a family doctor, are treated the same way, and they have to have some assessment activities. So as we move from CME into continuing professional development, this is self-directed, is around more competencies than the medical expert. It can be being a leader, being a communicator, being an advocate. This is multiple methods, including some unplanned learning, which happens in the workplace. And we think this leads to improved patient outcomes. But what we're really moving to in Canada is competency-based continuing professional development, which takes into account the needs of our publicly funded healthcare system, looks at performance in clinical practice, includes audit and feedback, and we believe this will improve patient outcomes. So talks like this in printed information, little or no effect on changing physicians' behavior. Clinical practice guidelines, which I've written several, and being a key opinion leader might help improve that a bit, but it's really these interactive techniques, outreach reminders built into electronic medical records, and audit and feedback, which can really change physician behavior and improve patient care. And this is a Cochrane review of audit and feedback, delivering performance around a physician's activities to them, and how that actually leads to a change in desired behavior. And this improved compliance with that desired behavior by only 4% in these 140 trials. But if you look at the interquartile range of 16%, 1/4 of studies had a bigger impact than this. And we know that this is more effective when the audit and the feedback comes from a respected colleague. It's given verbally and in written form. It's provided over and over again. And it has a target that you're trying to reach with an action plan. And in Canada, we've had 3 reports now on the future of medical education. More than a decade ago, undergraduate medical education, 2012 around postgraduate residency training, and now more recently around continuing professional development. And this talked about revitalizing our continuing professional development system in Canada to make sure that it's more evidence-based, it's based on practice data that's fed back to physicians, and that it's going to work to improve the experiences of patients, the population health, and our work-life health balance, what we call achieving the quadruple aim of care. And this report had 11 recommendations, and I'm just going to focus on this one around physician practice improvement, because this is now a new requirement where I practice medicine in Alberta, Canada. And it states that all physicians are going to be expected to do continuous quality improvement. They'll have to do a cycle where they're given data, trusted individual, aggregate practice data. You facilitate the feedback in hopes that this will improve patients. So starting next year, this will be a requirement for me to have a license to practice. I will have to assess my practice. I'll have to look at some data. I will have to create a plan where I think I could improve. I'll have to implement that plan, and I'll have to remeasure and complete the cycle. This is the way that now we're going to be required to do continuing professional development. And the hope is that this competency-based CPD will not lead to the ballistic model, but will lead to us continuing to grow as not only being competent, but proficient and continue to be experts throughout our entire career. So the physician learning program, which I've led now for 4 years, has this vision in my province that we're going to support a change in how we do CPD to be driven by this practice improvement. And I'll show you how we work with physicians to do this. And we've developed this audit and feedback framework and a way of working with physicians, working with administrative data to create reports for physicians and feed them back to them in group sessions where we bring them together. We share with them their data. We allow them to react to it because it's often unnerving where you haven't had any feedback since you were a resident 20 years ago to receive how you're doing compared to your peers. But understand it and think about ways that we can actually change our practice, commit to that change, make an action plan, and take it away. So I'll just share with you an example that we did with our own department that I started 4 years ago. Dyspepsia, as many of you know, is a very common problem. 1 in 5 adults will have upset stomach, heartburn, those types of symptoms. It negatively impacts their quality of life. And there are lots of clinical practice guidelines that say endoscopy is not recommended unless there are red flags. And we know that we have long waiting times where I work for getting in for endoscopy. And if we could improve that utilization, lower the unnecessary scopes, we'd have more access for patients that need it. And we've had a pathway just like our NAFLD pathway this was the original pathway that we developed with primary care around how to manage dyspepsia in the community with PPI use and H. pylori testing and treatment, and only really referring to a gastroenterologist if this isn't working. And so this Choosing Wisely Canada partners with different specialty societies to help enforce, things for family doctors to focus on. In the case of GI, one of the recommendations around do not perform an endoscopy for patients less than 55 without alarm symptoms. Do this approach that I've talked about, and only if there are red flag symptoms, do endoscopy. And after we started the project, the Canadian and the American guidelines changed, where they actually changed the age from 55 to 60. And even with red flags, these guidelines say that your yield of finding a cancer is very, very low in younger patients. And we know from the ASGE that you should be documenting why you're doing the endoscopy, and that 80% of the time that should be an approved indication for the scope. So we took 3 years of data in patients out of our EMR, younger than 55, for all of those patients undergoing endoscopy with dyspepsia. We excluded patients with the alarm symptoms. We linked to electronic databases to exclude patients that were iron deficient or had celiac disease that were probably appropriate endoscopies. And we still found that probably at least more than 1/3 of our endoscopies were low yield. And when we reviewed the pathology findings, we found no cancers. And we only found things that probably could be dealt with empirically without endoscopy. And we fed this information back. So every dot on this is a gastroenterologist in my community. And you got to see your dot compared to how your peers were doing. This was me over here. I did 1 scope in this 9-month period, and it was low yield. I had room for improvement. So when we went away and we did some things and people committed to changing the way they did their practice, we actually showed when we remeasured the data 2 years later that we decreased the amount of scopes being done for dyspepsia in these young patients. The percentage went down to 22% being low yield, and we saved on average about 300 low yield endoscopies. We didn't change the number of endoscopies. They were just being done for better indications. So this is an example of how we're changing continuing professional development. We're using audit of practice data and facilitated feedback to change physician behaviors. And this is now going to be a requirement to practice medicine where I work. I think this is an exciting development, but there's going to be a lot of pushback from our colleagues as we try to move to this competency-based quality improvement. Thanks once again for your attention, and for the opportunity to present today, even if it was remotely. Thank you very much.